Good morning, good afternoon, good evening, colleagues. You're so very welcome to our webinar today. My name is Olive Kokeman. I'm working as learning lead with the Quality of Care Network Secretariat in WHO, the Department of Maternal, Newborn Child, Adolescent Health and Aging. We've had a network national forum series running over the last year in order to share the learning that's coming from the 11 network countries. Next slide, please, Tala. So back in 2017, the Network for Improving Quality of Care, Maternal, Newborn and Child Health began. It kicked off with this very ambitious goal to have maternal and newborn mortality in learning health facilities in these countries that were participating in the network by 2022, and also to improve the experience of care. 4 strategic objectives were set: leadership, action, learning, and accountability. Next slide, please. But over the course of the last 5 years, there has been tremendous activity and progress in the countries participating in the network. This series would like to share the learning that has been taking place in facilities, in districts, and at national level. We want to share this because, firstly, as you saw, it was a strategic objective of the network to document and share this learning within and between countries. Sharing this learning is crucial to support policymakers, managers, and providers to have opportunities to exchange and learn from each other, to share challenges and practical solutions, which are actually saving lives with quality and dignity. We know this exchange is needed at every level, at facilities, between facilities, at districts, between districts, and at national level. But there's also extremely valuable learning to share between countries so that we can all learn from the work. So we are bringing this to you here today. The National Forums on Quality of Care for Maternal, Newborn, Child Health were a venue for sharing the experiences in adapting and implementing the quality of care standards, the strategic objectives, and progressing overall to achieve the SDG maternal, newborn, child health goals. And we have to note that their application occurred during the COVID-19 pandemic, which took over a good span of 5 years. So next slide. Across the 4 strategic objectives, there's prioritized learning that we would really like to be able to share. And that's what you're going to hear today from our colleagues. We want to share, in terms of leadership, how to strengthen and build quality of care health governance and management structures at national and subnational level to sustain the action for quality improvement. We want to learn how to link the learning from the maternal newborn health implementation side with management decision-making processes at district, facility level, and align this with the local health governance systems. We want to learn, how do you establish a learning system that can support and share quality of care knowledge within and across districts and scale up quality of care practices from the learning districts to other districts in the country. And we also want to learn how to advance the huge challenge to strengthen routine measurement systems to collect, report, and use quality of care indicators to improve and sustain quality maternal newborn care. And also how to develop and implement accountability mechanisms that can integrate the community and stakeholder perspective that inform quality improvement also. And so next slide. Today, we are very happy, we are delighted to be able to welcome the Ministry of Health Uganda to share with us the conversation, the learning, and the next steps that came from their National Learning Forum. We welcome Dr. Elizabeth Namagala, Quality Improvement Advisor, Ministry of Health Uganda, who will present these learnings. And then we will have a questions and answers that will be facilitated by Dr. Martin Sendonia. He's the Acting Commission, Department of Standard, Compliance, Accreditation, Patient Protection at the Ministry of Health Uganda. So for the questions and answers, please pose your questions into the chat box. We will curate them and Dr. Martin will be able to pose them and we will have a big discussion on what you're seeing presented now. So over to you, Dr. Namagala.
Yes, good afternoon, ladies and gentlemen. Good morning for some of us, I think in the US and elsewhere in the West. I'm Dr. Elizabeth Namagala, Quality Improvement Advisor attached to the Ministry of Health Uganda. And under the Standards Compliance Patient Protection Department. This is a presentation outline. I'll briefly talk about MNHCA status in Uganda, and then also some updates from our Uganda National Quality of Care Forum that we held in May this year. Then about a few slides on the quality of care progress, what we learned under leadership, action, learning, and accountability, strategic objectives of the MNH quality of care network. And then finally, I'll end with the next steps. Next, please. The status of MNHC services in Uganda. Uganda's population stands at 46 million as of 2022, and we still have a high fertility rate of 5.4 children per woman. Our maternal mortality rate is on a declining trend, but really slow and remains high at 336 deaths per 100,000 live births. And the data I'm quoting is data from our Uganda Demographic Health Survey that was done in 2016, where we are yet to receive more current data. So this probably has actually gone down over time. Under 5 mortality rate has declined from 90, that was in 2011, to 64 per 1,000 live births. Still the same data, UDHS 2016. Neonatal mortality rate has stagnated over the past decade at 27 deaths per 1,000 total births. Stillbirth rate declined from 24 stillbirths per 1,000 deliveries in 2014 to 17 stillbirths per 1,000 deliveries in 2020. Our modern contraceptive prevalence among married women is still low at 35%. That is still below the desired 50% for the country. That's the map of Uganda. I think, as you can see, we are bordered by Kenya, Sudan, Congo, and Tanzania, and Rwanda. Next, please. Next slide, please. Yeah, the data I'm presenting is data that we've been able to collect from some of the core indicators that we're monitoring under our MNH quality of care program in the country, and we are getting data from our DHS Saito. This is a health management information system data, and it's data for the whole country. But I just want to share that actually we are implementing MNH quality of care, the 8 standards that were adopted from WHO, in only around 73 districts, and we have around 140 districts in the country. So it's just half of the country that's really been implementing. But because we've had other funding in the country that is focusing on MNH quality of care, we are presenting data across the whole country. So this data is showing institutional maternal mortality ratio from 2017 to 2022. And our data shows a noticeable reduction in maternal mortality ratio from 121 in 2017 to 86 in 2022. Our national target that we had set was 78 per 100,000 deliveries. Kampala, that's the capital city, reported the highest institutional maternal mortality rates. That's greater than 200 deaths per 100,000 deliveries, mainly because a lot of referrals, self-referrals, even those referrals that are from lower facilities take longer to come, and they die from Kampala, but they are not necessarily from Kampala. The other region that has high institutional mortality rate is Bunyoro. Surprisingly, Bunyoro and Kampala have not been, are not part of the districts that have been implementing the MNH quality of care standards, apart from Kampala recently just started implementing under support from USAID. But this is the data. This is the same data, but broken down by the region, as you can see, from 2017 to 2021. Postpartum hemorrhage case facility rate is still, case fatality rate is still high for postpartum hemorrhage. It's around 2.4% of women who present with PPH will die. And it's still also very high for Kampala and Uganda when you break down the data by region. This still has high, but Kampala also still has high case fatality rates. And then next slide, please. Stillbirth rates, that is fresh stillbirths and macerative stillbirths, but for 2017 to 2022 data, we've also seen a noticeable decline in intrapartum stillbirths from 21 per 1,000 live births in 2017 to 13 in 2022, but we still have high stillbirth rates in Kampala and Bunyoro when you break up this data. This is data for the whole country, and then this is data per region, same data but broken by region. Kampala still has high stillbirth rates, and Bunyoro at 18 and 22 respectively. Next slide, please. Preterm birth rates 2021 to 2022. From the last two quarters of 2021 to the first 2 quarters of 2022, the data shows that preterm birth rates is about 30% per 100 live births, but Kampala still has the highest stillbirth rate at around 69 per 100 births. That is this data that is broken down. The same data broken down by region. I think you can say that Kampala still has about 69% of births as preterms, and about 61% of our preterm babies are underweight, which makes them very much at risk of death as well. Next, please. In Uganda, we were able to hold our first National Learning Forum. The picture just shows a snapshot of what was of the attendance. It was well attended. It ran from 24th to 26th May 2022. We got 210 participants. Most of these participants were facility health workers, frontline health workers, implementation partners, and national level partners. And it was co-funded by Government of Uganda and partners. So it was really a joint activity with very good participation of partners. It was officiated by the Minister of State for Health, and also the US Mission Director. So it was really well attended by partners at a high level, and also by WHO Geneva. And we received several keynote addresses from partners and academia, both international and locally. Yeah, so from our national forum, we were able to learn that first of all, engaging partners created a lot of enthusiasm in our partners and improved availability of funding for scaling up of MNH quality of care in all regions. As I said, we're implementing over 300 facilities across 73 districts, which is roughly half the districts in Uganda. And we've learned that engaging politicians positively improved implementation and effectiveness of MNH quality of care interventions. For example, partners have contributed significantly to ambulance services, and we've been able to also gain support. Like, for example, one of the facilities was able to get some of the money from their private wing to support mothers who are not able to support commodities for cesarean section in some of the units. For example, Chiliandongo in northwest Uganda. And then also we've learned that understanding root causes of gaps and problems improves design and effectiveness of facility MNH quality of care interventions. We've also learned that strengthening maternal and perinatal death surveillance and response systems at all levels improves health facility participation and effectiveness of MNH quality of care intervention. Because as we do these death audits for mothers and newborns that have died, we are able to link them directly to quality of care interventions immediately. And we target those facilities that have high mortality, especially because we are doing it every week at all levels. And then strengthening of community engagement at all levels has been slow to address challenges in managed quality of care implementation. So this is an area that we need to still work on, especially because none of our standards is actually touching community engagement at the moment. Next, please. Quality of care progress as per strategic objectives leadership. Well, first of all, as a country, we followed all the steps that were outlined in the WHO framework. We're able to establish a leadership group at the Ministry of Health that is under Maternal and Child Health Department, and also the Standards, Compliance, Accreditation, Patient Protection Department, under which Dr. Sendion and myself are working. And then we're also able to do a situation analysis with support from School of Public Health and WHO. We were able to adopt the standards of care from WHO. We adopted all the 8 standards, although we are not implementing all of them at the same time for some of the regions, but most facilities target to implement all the 8 standards. And then we've been able to do quality improvement interventions, but targeting packages, clinical packages of care that we developed that are actually targeting the major causes of mortality in the country. For example, most of our QI interventions have looked at a strengthening of cartograph use, reducing decision time for surgery sections. We've developed simplified guides for health facility teams to be able to address mortality. They are able to identify the QI interventions as per the gaps they've found using the simplified guide. We've been able to also roll out postpartum hemorrhage and preeclampsia, eclampsia bundles within the facilities. So we are using the plan, do, study, act cycle as we implement QI interventions following our national QI strategy, as it already outlines. Because as a country, we've already been doing QI in other for HIV and PMTCT, so we've really used the same structures to roll out MNH quality of care as well. Next slide, please. Under leadership, the Directorate of Governance in the Ministry of Health is in charge of continuous quality improvement, and it's actually providing a strategy for maternal newborn quality of care. That's Dr. Kware, who is the director. And as I said, we've been implementing MNH quality of care within existing structures for continuous quality improvement. And we have national guiding documents that are already there. I think for now, we are in our second strategy, national QI framework and strategy. So we are using that to implement MNH quality of care as well. Implementation guidelines have been developed for QI across the continuum. So we've also included family planning. Although we've not rolled out other areas, we're still focusing on maternal and newborn health. But our main stage, the whole spectrum is we've developed implementation guidelines to guide and also assessment tools to guide implementation here. Monthly MNH quality of care network planning meetings are being held, and these are actually the actual network members, MNH quality of care network members. We meet monthly, basically to guide, harmonize implementation, and also to share learning and best practices, especially for the people who are implementing, the implementing partners within the regions. Next, please. What we've learned in terms of leadership is that nesting quality of care within departments of maternal child health and the standard compliance, accreditation, and patient protection and Ministry of Health has enhanced guidance and stewardship for quality of care efforts in the country, including partner coordination. And then also engaging leadership has enabled us to mobilize funds. We've been, although not only half of the country was implementing the MNH quality of care standards, we're able to get funding to support MNHCS services, especially in terms of equipping and improving infrastructure and also implementing results-based financing that is focusing on improving MNHCS services using funding from the Global Financing Facility. The country was able to get a loan from the World Bank, and for the last 5 years, they funded, and most of this funding has supported MNC services. We've been also been implementing quality of care within existing structures for CQI, as I said, for continuous quality improvement, and this has enhanced sustainability and institutionalization of MNH quality of care. We also have rolled out a regional strategy that strengthens the capacity of regional referral hospitals to coordinate support supervision, quality improvement, and performance monitoring at the regional and district level, which has strengthened governance and supervision for MNH quality of care. Next, please. Under the action strategic objective, the country adopted the 8 WHO MNH quality of care standards. Actually, we did it in 2017, although the rollout took a bit some time, but we were able to come up with an MNH quality of care package that targets the major causes of maternal and newborn deaths. And also we came out with a clinical mentorship package as well. We've been able to operationalize our national MNH quality of care working group. That's the one that meets monthly and consists of members of the MNH quality of care network. We have implementation guidelines and a framework for network objectives that has been developed. And our national capacity and district capacity for rollout of MNH quality of care training has been built because we've trained trainers of trainers using the point of care CQI model. We have over 250 national and district trainers of trainers. We have scheduled hands-on support, that is mentorship and coaching, to all our learning sites. As a country, selected 18 learning sites within 6 districts where we've been actually getting lessons that are helping us to scale up beyond those 6 learning districts. And we've used district-led supportive supervision because it's easier, because those districts people are there near the facilities. It's cheaper than using central teams. Next, please. Under action, we've been able to conduct maternal newborn health quality of care assessments using our adopted MNH quality of care assessment tool. And also, as I said, we have our MNH quality of care guidelines across the life course. We are yet to roll out in other areas, especially the small and sick newborn and family planning, but we've developed tools for these as well, so just ready to roll out. Our weekly MPDSR and National Safe Motherhood Executive Committee are held at national level weekly, and they actually they give prompt linkage of quality of care to address identified root causes. We are able to get where the mothers have died and why they've died, and actually intervene. As within a week, we're able to intervene with quality of care interventions. We've developed and disseminated essential maternal and newborn care guidelines. And also we are using learning from implementing facilities to guide further scale up in the country. Next, please. This is the adopted mentorship package. We have under the World Bank project, we were able to support a clinical mentorship package that is looking at skills building, and we are rolling out skills building using these packages. We have a package for helping mothers survive, helping babies breathe, pediatric emergency triage and treatment, including IMNCI, integrated family planning, adolescent health package. So the whole package, as you can see, including basic anesthetic skills and CQI and also infection prevention have been included in clinical mentorship. So in addition to quality of care and quality improvement mentorships, we are also giving these clinical skills to facilities. This actually goes across the country beyond the 73 facilities that are doing MNH quality of care implementation. Next, please. For the 18 sites that we selected as learning sites in the 6 districts, the few districts that were able to see a lot of improvement in their facilities was Anaka General Hospital in Noya District. As I said, this is one of our learning sites. This slide just shows that that we have seen increasing numbers of mothers that have had C-section within an hour as a result of implementation of quality of care in this district. This graph just shows mother section within an hour. This is the green graph and the total cesarean section. So you can see that the proportion of those that are sectioned within an hour has actually increased over time. If you see from this data is from February 2020 to December 2020, but you can see that the proportion of mothers sectioned within an hour is actually very, very high. And this is the same graph. It shows that this number has gone up over time. And this is supposed to be a median, but you can see that the mothers that are sectioned within an hour after the decision to do Caesar has been made, has improved over time because of quality of care implementation. Next. We've also had improved postnatal care visits at 6 weeks in one of the learning sites, that is Chigumba in Chiriandongo district. This is a site that tested, it identified staff to provide postnatal care and to monitor postnatal care attendance, and got mothers with risk factors and followed and actually gave them appointments. And also they were able to give them soap and basins. And they reviewed and integrated, strengthened postnatal care within existing services. So as a result of this facility has seen attendance of postnatal care at 6 weeks increase to up 100%. This is data from one site. Next, please. Under support from one of our partners, UNICEF, UNICEF is supporting the Karamoja region and Western region. They've done a lot of infrastructure improvements as part of implementation of MNH quality of care. They've set up 9 maternal high dependence units at hospital level with a total of 33 bed capacity. And they've also trained health workers 185 health workers in critical care have seen admissions improve as a result of this, and also maternal survival rates up to 95%, 97% because of this intervention. I think this is just showing you that outcomes in the health, in the high dependence unit, admissions have gone up since it was set up, and also trends in admission in NICU. They've gone down, but the fact that there's a NICU means that they are providing better care for our newborns in these facilities. Yeah, so we are yet to see data for this region. But data also has shown, we don't have data from these regions that are supported by UNICEF. But when you look at the institution mortality rates for facilities, those deaths have actually gone down because of these interventions by UNICEF. Next, please. Under also UNICEF support for the West Nile region and Karamoja, they've used Boda Boda, which is a motorbike ambulance system. It's a simplified system because it's the most accessible transport at the lower level in the community. They've been able to improve referral using Boda Bodas. Mothers are given vouchers that they use for transport when they're in labor. And out of this intervention, they've been able to refer 46,000, over 46,000 referrals, 40,000 pregnant women of these, and 5,700 children with danger signs were referred using this system. So it has somehow improved referral, because we've seen that referral delays in referral and the major causes of most of our mothers, because they come late because of issues of transport. Next, please. There's been procurement and distribution of ambulances in the Busoga region as a way of reducing intra-facility delay. As I said, this is a major cause of death. 7 Toyota type ambulances were distributed to the following facilities. These are Jinja, Referral, Botagaya, Mayuge, Nankoma. This is a region that is being supported by WHO to implement and manage quality of care. And this has actually gone a long way to improve referral systems, because sometimes you actually have to really do in-kind or actual provision of transport to improve the referral systems. So they've been able to provide these in 7 facilities. And that's a picture of the ambulances that were procured and distributed in the Busoga region. Next slide, please. Lessons learned under the action objective. We've seen that partner engagement and participation has enhanced scale-up of implementation because many partners, actually most of the regional implementation is by partners. Over 75% of these are USAID funded, but we also have UNICEF and also other partners. Weekly MPDSR and National Safe Motherhood Executive Committee meetings have been very important in providing early linkage to quality of care interventions and addressing root causes of maternal and newborn deaths. And also the development of essential and maternal and newborn care guidelines has improved the delivery of evidence-based care in the MNC setting. So we are yet actually to even further disseminate these guidelines to improve evidence-based care. And this is under standard 1. Next, please. Under the learning, we've seen that implementation of MNH quality of care within 6 learning districts has helped inform further scale up in the country, because the lessons we got from the learning districts have been used to scale up within the other regions. We've also been able to implement peer-to-peer MNH quality of care learning sessions that have been incorporated within district performance reviews in learning districts. This has enabled scale up of successful QR projects. For example, the reducing of cesarean section decision to incision time is one of those tested changes that have actually spread across the country, because we've learned from what Anaka Hospital did, and it's one of those that has really worked very well across the country. And also MNH quality of care collaboratives in 65 districts that is being conducted. The collaborative for MNH quality of care is in 65 districts. It conducts quarterly learning meetings at the regional level and national level, and it has actually enhanced learning because facilities come and share, and these same meetings we are able to harvest and document the learning so that we inform further scale up. We've also been able to set up committees of practice that have enabled us to have a platform for continuous knowledge exchange. And also at the national level, we've been able to to form national forum for learning and sharing in form of the annual Safe Motherhood Conference. We've so far had 2 Safe Motherhood conferences. We just had one last week. And then also we're able to hold our first maternal newborn quality of care forum in May this year as a national platform for sharing and learning. So we've seen that actually learning districts are very, very important in informing national strategies for additional scale up to regions, and also implementing MNHPY collaboratives help improve learning because of the quarterly and annual meetings, and the improved sharing and harvesting of learning across districts. And then also webinars on postpartum hemorrhage and other major causes of maternal and newborn mortality, and communities of practice have created national platforms for continuous exchange of information and learning on MNH quality of care. And then I've already mentioned that we have the Safe Motherhood and MNH quality of care forum that are already national platforms for us to learn and share innovations and best practices in MNH quality of care for the country. Next, please. Accountability, 11 of our 15 MNH quality of care common core indicators are already captured within our national health information management system, that is the DHSI2. And we are, as a country, these core indicators are being monitored through direct data collection from facilities, and then scheduled visits actually are conducted to learning sites that have been the major source of some of this data, and then the data is reported. With support from WHO, we're able to improve the USAID hybrid HIV database. We modified it so that we are able to capture data on experience of care and watch indicators which are not being captured in our DHSI2. We've also established a national QI database, which captures the core MNH quality of care process indicators. So we're also able to collect data from actual facilities that are implementing beyond the HMI system. And also we have facilities actually can report from this national QI database straight without, I mean, we get data from HMIs, but we get additional data from this national QI database. And we're able to capture data on the actual tested changes and the data from the QI interventions being implemented. Progress on MNH core indicators is presented monthly in our MNH quality of care learning meetings and quarterly performance review meetings. And then weekly MPDSR reports are presented during the national, regional, and facility level MPDSR meetings for accountability. This has really actually improved accountability because when a mother dies or a baby dies, people know that health workers know that every death of a mother and of a newborn has to be accounted for. And we've made it that actually they are not penalized. It's not because we are penalizing them, but because we have to understand why these mothers have died so that we improve our services for them. So that has improved accountability. This is just a slide showing that of the 15 core indicators, 11 of them are already captured in our HMIS. So wherever there's a dash, we already captured that indicator in HMIS. And wherever there's an X, you're not capturing that. Next, please. But it's basically experience of care and the watch indicators that are missed out. Next, please. Accountability has also improved because of engagement of stakeholders. With the support from White Ribbon Alliance, we've been able to foster the creation of accountability mechanisms. We have created fora for accountability with the Health Committee of the Parliament. Parliamentarians have been mobilized to sign up as champions for respectful maternity care. We've had several engagements with the media that have been held to promote respectful maternity care. And the country has started the process of domestication of respectful maternity care in the country. Next, please. So what we've learned under accountability is that the national QI database has allowed capture of the core MNH quality of care indicators and additional process indicators that have not been captured in our HMIS. And also the fact that modifying the HIV database has enabled the collection of data on the experience of care and watch indicators. And also the fact that we are presenting progress of MNH core indicators in our monthly meetings helps us enhance monitoring and evaluation of implementation. And also the fact that facility level MPDSR meetings and weekly MPDSR reports during national MPDSR meetings have contributed to improvement and sustainability of MNH quality of care. Actually, these MPDSR meetings are within the national systems. They are part of the routine running of maternity settings within our facilities, and also at the national level, we are having weekly MPDSR meetings where all the deaths that have happened in the country are reported at national level and discussed and linked to quality of care interventions. And actually we go out and look out where, if a mother has died, we are able to actually identify that most of the deaths at Mulago, at the National Referral Hospital in Kawempe, and also from Bunyoro, we're able to identify that most of these deaths are actually referred cases that have come late. They actually present to die, mainly because of the weak referral system. So we've actually gone ahead, try to strengthen the regional, at the regional level, try to improve theaters so that mothers, instead of being referred long distances to Kampala and or to other regional referral hospitals, we are able to do the cesarean sections in those regions. So we are able to address the problems within those sites that are referring so many of these mothers to other facilities. Next, please. So we've had challenges implementing MNH quality of care in Uganda. First of all, the high dependence on donor support. Most of this scale up, we expect partners to support it. However, as I said, we're able to get a World Bank loan under the global financing mechanism that supported the results-based financing program in the country, and also supported infrastructure and wash improvements within our facilities. So we hope that we'll get further funding from government through maybe, I don't know whether it will be another loan, but we still have high dependence on donors. And then the other thing also that we've seen is that MNH quality of care interventions need a lot of money, especially in coaching, in terms of coaching and mentorship for health workers, especially when they've just been trained. They need to be followed up. Moreover, regularly, maybe for the first 6 months, they need to be followed up on a monthly basis. And this intervention is quite expensive, and funding for these activities has been quite low. Then also we've seen that we've had inadequate community engagement in implementing MNH quality of care interventions. And we've seen from our national forum, we saw that actually this was a missing link in most of our facilities. They needed to engage the community to be able to deal with some of the issues that they are facing at the facility level. Then we also have inadequate staffing for many services, especially for critical staff. Our staffing norms for maternity are outdated. The numbers of recommended midwives, and even the doctors, the numbers are too low. Even if they are all full, people are not able to cover services well. They are overworked, so they are not able to do some of the things we expect of them because they are too few. We still have gaps in our referral systems, as we said. A lot of districts lack ambulances. They have to be linked. One ambulance actually can serve like 4 facilities. It's the same ambulance moving across, and also fueling them is another major gap. Infrastructure and implementing experience of care standards has also been a weak area. Experience of care, we are still learning on how to implement the standards on experience of care. That is standard 4, 5, and 6. We are still learning more on how to do it better. Then, although we have had some success stories from Noya district, we are yet to roll them out better in all the regions where we've scaled up. We've had continued outbreaks and epidemics. I think the COVID-19 and Ebola have really affected implementation of MNH quality of care, especially during the scaling up phase. COVID-19 really affected us. Next slide, please. So our data capture is largely paper-based. That is actually it's time-consuming. Midwives have to see long lines and then have to go and update registers. Sometimes they have very long lines, so it's very hard for them to update all that registers and be able to attend to patients. So they usually do this work after they've seen patients, and that also hampers. It affects the quality of data sometimes. Next, please. We've formed new partnership with some of the partners to fund MNH quality of care, like recently with Rotary, the Rotary in Uganda. And this is a picture showing one of our partners signing, I think that's WHO, working with Rotary International. They provide funding to support, actually they've supported maternity improvements in a number of facilities. So it's very important to engage them. And for most of these partners, they are always willing to support maternal and newborn health services. Next, please. Our next steps, organized according to the strategic objectives for MNH quality of care. Under leadership, we want to strengthen participation of all partners and stakeholders in attendance on national monthly MNH quality of care meetings, and also sharing, because these are meetings we hold where we learn, we present what we've learned from implementation within the regions and facility level. Under action, we want to implement national QI collaborative. Our QI collaborative is only 65 facilities. We want to go beyond and have a national QI collaborative for the whole country so that we can scale up best practices and the lessons we've learned. We want to increase the scope of implementation to include child health, family planning, and nutrition, quality of care. We have already adopted these standards for all these areas. Also, we plan to disseminate the essential maternal newborn care guidelines at subnational level for better impact, and also want to disseminate the small and sick newborn quality of care standards. We've not yet disseminated them. Under the learning, we want to scale up platforms for learning, the National Safe Motherhood Executive Committee meeting, and also local maternity and neutral systems. We're planning to scale this up as well. Under accountability, we want to capture all the 15 core indicators. Not all our MNH quality of care indicators are captured in DHSI2. So we hope that in the next review of our DHSI2, we'll be able to capture all the indicators under this under the DHSI2. And then also there's an ongoing evaluation of impact in the 18 learning sites for MNH quality of care with WHO support. These results maybe will be released soon, but data collection has been ongoing. And then as the other thing, we want to do resource mobilization through corporate society for maternity. We want to do more engagement of the corporate society, because as I said, there's a lot of willingness. If we engage them, there's willingness for them to support, especially the infrastructure improvements that we want to see in the maternities. And there's going to be a launch this month on 4th November for this corporate society for maternity. And this is actually a drive by the Ministry of Health, led by the Permanent Secretary of Ministry of Health. And then the other last thing is that we are planning to domesticate the Respectful Maternity Care Charter with support from the White Ribbon Alliance. Next, please. Conclusions, I think we've seen that we'll need a survey to ascertain the actual root causes of persistent high newborn death rates in Uganda. We need to, because we are doing quality improvement, but we feel that probably there's need for us to do a survey to ascertain the root causes of this. And then also increasing funding for essential medicines and commodities and infrastructure improvements will require enhanced advocacy efforts. We've seen that actually for some of these some of this funding to improve, we need to really lobby at higher levels to ensure that allocations for medicines, commodities, and infrastructure improvements are increased within our national budget. And also maybe also do more advocacy efforts with our partners. And then finally, the desired improvement in quality of MNH services may not be achieved if we do not address human resource issues in Uganda. I think one of the things that has happened at maybe as a result of advocacy and discussions, we've seen some improvements, especially in funding of the health workers. I think there's improvement of remuneration of health workers in the country, but we still see that the numbers of health workers, we are understaffed in many of our facilities because staffing norms need to be updated. So unless we address all these human resource issues, we may not be able to see some of the things we want to see in terms of improvement of MNH quality of care in Uganda. Next, please. Yeah, that's the end of the presentation. Thanks for listening.
Thank you much, Elizabeth, for sharing the presentation. Sure, it was a long story. It's a long story, and this could certainly go on and on. But I want to appreciate you all for it. So I want to appreciate you all for attending this presentation, and listening from the Ugandan side of the story. We have a number of questions that run through them. We have shared them on the chat platform. With the team on the ground, WHO and the team is with us. They'll be answering some of the questions. Of course, the presenter herself, who has a long experience in the point of care for MNCH, and our other partners, Partners International with us. So we shall try the best to answer the question. And the first one was to do with somebody wanted to know more about the lessons learned in the National Learning Forum, and relating this to understanding the root cause of gaps and problems to improve designs and effectiveness of the quality of care interventions. Olive, do you want to respond to this? Olive, are you? Yeah.
Hello, Dr. Martin. Thank
Our
you so much.
National Learning Forum, we learned it. We had it from the 24th to the 26th of May. Had it in Kampala, and had a big turnout for the participants. A lot of experience was shared from the implementing sites in different parts of the country. Capacity has been built, especially in the implementing units for maternal, newborn, and the child health, to address, to appreciate the gaps that are within the facilities and deal with them, and coming up with what we call the quality improvement objectives, and then looking at how they can address the particular interventions. We shared about the decision to decision time component, which has been addressed in a number of facilities, and use of the pathograph to improve the outcomes in deliveries. So also a lot was shared in this forum, and I think it was an opportunity for our country to bring together on the same level the different actors. The question about whether the users of MNH services, their role, we are in the process of implementing care. We engage them. There are the opportunities for them to be involved. We have the feedback mechanism have been established in a number of facilities. Regional hospitals, they are bigger centers, 16 of them now in the country. They have what we call client tutors, and the opportunities are really there to get the feedback. They exit interviews are also conducted when you do the assessment of care standards, and also when we go for community engagements, in the fora where our community workers participate, again we can get more feedback from these service providers, users. Then on the issue of how the innovations of cesarean section scaling up from hospitals to other facilities, how this one, how much we appreciate this story about it. Yeah. Elizabeth, you want to comment on this? The issue of the innovation of cesarean section scaling up on one facility, from hospitals in particular to other facilities, improving the quality of services. The question was, somebody wanted to know more of the factors that helped to improve the cesarean section, factors that helped to improve the quality, to improve cesarean section within 1 hour incision, some of the factors that contribute to that. But again, around this, people have been trained, as I mentioned, had mentors and the regional mentors. They've been to general hospitals and health center to really build capacity in ensuring that we improve in in our organization and our teamwork to make sure that services are provided in time, especially for emergencies. Mothers who come and they need to be given service. The teams have been working on this. They've been meeting, they hold meetings in their facilities to look at these challenges and see how they can be addressed in better ways. And we've been assessing them through supervision and also monitoring to see that they do this work better. So this has been some of the factors. And scaling up, we've been working with our partners. Many partners have been participating, especially in the learning exchange meetings, hold and performance reviews. They're either at regional level, and the best practice is picked and shared. We as the country, we are coming up with the policy position to see how some of this best practice can be taken up. We are working on the guidelines. We are operationalizing the guidelines for WHO of care, implementation guidelines, and we are putting some of these elements to be practically accessible and used in the scaling up process. Then there was also a question here, how would we identify the need for implementation of intervention areas that we've been addressing. The intervention areas, how would identify them, and some of these would do. We involve the stakeholders. The intervention areas, in the sense of the challenges we have on the ground, would come from the assessments we undertake using the MNH tools for assessment of care. They would give us some of the elements we need to address, and again work the implementers on the ground. The issues be identified in that way. We are again looking at the capacity on the ground and also the available logistics and the other inputs. Then there's also another question: do you consider the end-use experience developing the interventions related to care? Yes, we do. And again, this one we get it mostly when we have these learning exchange opportunities, including the forum. We would get a lot of those who have been involved in the interventions, the experience they have, and most of this will come out very distinct, and document and use it to get other actors also do the same in one way or another. The Kampala data, and also there's also Hoima. Kampala is in the same country. Hoima, this saw the spikes of challenges of postpartum hemorrhage and stillbirths, and we are familiar with some of the factors, because this being a referral centers, most of the mothers, when they get problems, they are failed to handle their problem elsewhere. They are referred to these centers specifically. But also we are mindful about our referral mechanism. The capacity we are building needs to be considered seriously, so that the rural facilities can handle as much as possible, so that we don't have so many difficult cases referred to one center to be taken care of. So, but it is true, we need to look critically what would be other factors beyond those obvious ones that we need to address and improve service deliveries. Ambulances, the government bought ambulances using the funds from the World Bank.
Sure, WHO in Busoga is receiving resources from Koika.
And a number of more than 100,
and his
even more ambulances were procured. But the partners also do procure ambulances the gap is still there. They still have a whole department in the ministry which is addressing the issues of improving the use of ambulances, because you can lose them as fast as you buy them. So the mechanism has been put in place to improve the utilization and getting value from money. The regional centers are being considered, so they are coordinated at one center instead of buying so many for each of the facilities you have. You come to you come with one over another. So the procurement is by different actors, and we think it is helping us to improve the referral in those areas. Your national data on board of care, is there available? Is there data available? The results from all facilities are the different facilities work different things. And in this way, why are they right now? The data issue is something also we are getting a lot of interest about. We work with the agent responsible for data management at the ministry to give us the national level data for the key performance indicators, maternal mortality ratios, the infant mortality, newborn, and others. So when we work with them, they have the two departments, key departments, and WHO work together and partners to make sure that this data is clearly available. And they also can work with the districts and regional public hospitals that this data is available and used. But we have come up with what we call the quality improvement, 5S quality improvement database, which is helping, which we think is going to help us to include other elements which are not captured in the DHIS. And we hope things should get, there should be more capacity to access data at all levels. And more important, now I want to see them improve the utilization for data-driven decision making. So that is, I think, then there is another question. And do you plan to conduct nationally representative sample survey of facilities on the quality of care? Yes, we are planning to do that. This year we have conducted SARA, Service Availability and Readiness Assessment, now called Harmonize the Health Facility Assessment. We have conducted and we are doing data collection, we are doing data analysis and report writing. The focus was on availability and readiness. We are planning to do the next short time to come to focus on quality of care and the finance and management components of HHFA. And we think it's an opportunity we are considering for that purpose. So do you do direct observation method for code of care assessments? Yes, we do. We have the tools, we have the national level tools, which cut across the board, but also we have the MNH tools for code of care assessment. And they give the different assessment approaches that we need to put into consideration to capture the relevant data that we need. What
Thank you so much. Dr. Sadiana, thank you so much. We have come to time now. Can you hear me?
Olive, do you want to comment on indicators? Dr. Olive, there. Or Elizabeth.
So, sorry,
Thank you.
Sadiana. Yeah.
Yeah, thank you very much for those questions. I think my colleagues, I think I would ask Dr. Arnold to share and Dr. Kajimu to share more on this decision to decision time, some of the work that is being done, the tested changes, but most of it has been improved training of health workers, the teams that are in maternity, to really identify these mothers that need scissors. As once they're identified, there's early linkage to the theater. Theater must be prepared, and commodities, supplies for cesarean section are at hand. They should be available. And they've also improved availability of staff that are on duty. They can be called whenever there's once the decision has been made. Staff are available to do this the cesarean section within a short time. the other thing that we say, all this data from facilities actually is available because we have a national QI database that actually captures the actual tested changes at the facility level. And then the other thing that I think people have touched on, the question has come out about, oh, I'm losing the, there was a, sorry, there's a question on or how do we select interventions for facilities? First of all, facilities during the training, we told facilities that they should actually do most of the interventions, should target the data they collect, because our maternity registers are already collecting data on certain indicators which are summarized on a monthly basis. All this data on stillbirths is collected, maternal deaths, newborn deaths is collected and summarized on a monthly basis. So they should be reviewing this data, and this data can help them generate gaps in performance and actually target this. But also data, I mean, MPDSR reviews are also generating a lot of areas that are showing gaps, and actually they're also connecting their findings of MPDSR to quality improvement as well. Then we've already selected our prioritized care packages that address the major causes of maternal and newborn deaths, which are also areas that have been pre-selected. We do not actually prescribe packages as such, but we have those prioritized areas where we expect facilities to get tested changes from, addressing those major causes of mortality in newborns and mothers. For example, testing changes that are going to reduce postpartum hemorrhage. I mean, we'll find almost all facilities are going to be selecting that, and also improve labor monitoring as well. Decision to incision time. These are some of the prioritized areas that are sites already selected. Then we have also developed a simplified guide for MNH point of care that allows facilities to actually connect their gaps to the selected interventions as guided by the MNH point of care standards. So that has also helped them be able to prioritize, but we actually tell them to collect data on those indicators that are already collected within their register, so that they don't create additional work, but they are able to use the data that is already being collected. The other thing, as I said, we already have this data we have a lot of data. Actually, we're able to collect data from HMIs, but also from the national QI database, which is actually being rolled out, and many facilities are already implementing. I'd also request our colleagues from Dr. Arnold and Dr. Kajimu to make comments on some of these as well, and Dr. Sentrumbwe. Over to you.
Thank you so much, Dr. Namagala. We are at time now. We are ahead. Could we ask you for a final remark? Dr. Sedinyana, would you have a final remark? We have just reached.
I know that it's not getting us clear, but I want to appreciate the questions. There are many. There are enough, but also the issue about some facilities and districts are not performing well. Yes, we have them. Some of them, they have different factors, as we have shared. The issue about leadership is very important, supervision, coaching, mentorship, and also there could be resistance to change. So we have to do a lot of capacity building and also empowering in the best way possible to get better results out of the difficult areas. And
thank you.
The same applies to resistance, reluctance of facility staff to implement, to move along with the change. So many times we need, once you get a critical team, critical mass, a number of service providers that are willing to work, and you engage them, and you begin with those ones, and you see how the others can also follow in the long run. But it's a challenge also which you can't do away with. And then we also the issue of stillbirths and other performance indicators where we have seen we are still high. We are going to do more analysis and see that we come up with practical solutions to address the challenges. The questions many have tried to run through them. But Dr. Olive, can you make some comments, please? Olive?
I'm going to have to say thank you so much to the
Olive
team for
Arnold.
Yeah, this is Olive Kokoman back here again. Thank you so much for the team from Uganda. This was an absolutely excellent presentation in terms of a lot of information across many topics. Thank you so much for being so good to go through each question and make sure to respond to all the questions that came up from the participants. Any question that is outstanding, we will share with the country team to get the responses. And we will be able to share this recording, the slides and any outstanding question responses. We cannot thank the team in Uganda enough for this huge amount of work. It's incredible. There's a lot of praise coming through in the chat box. For all of this that you have been driving forward for the last number of years. We wish you every success and strength in continuing this work, in scaling it up further to further health facilities as well, and being able to share the learning further. This has been a great webinar, and thank you all for joining. We will have another webinar in this series coming up in the beginning of December. We would like to share the results from a quality of care conference that was recently held by the Ministry of Health in Malawi. Just in the middle of October, there was a conference very much focused on quality improvement, maternal, newborn, child health. We'd like to share that with you, the content, the lessons learned, the next steps moving forward as Malawi take the same journey as Uganda has been taking with us in the network over the last number of years. Thank you so much for your participation today. Thank you so much to our colleagues at the Ministry of Health in Uganda, and also to our colleagues in the WHO country office, to Robert and Olive for supporting us today with this presentation development, and to Dr. Namagala, Dr. Sidiana, thank you so much for your time today.